All right. Without wasting time, let me introduce today's guest speaker, Dr. Viresh Chopra. It is my great pleasure and honor that we gather here today on this virtual platform to extend our warmest welcome to our esteemed speaker. As we come together from various corners of the world through magic of technology, it is testament to the power of connectivity and shared knowledge that binds us all. Today we have privilege of hosting a speaker who exemplifies excellence in the field of endodontics and has dedicated his life in pursuit of knowledge, innovation, and inspiration. Our speaker's journey has been marked by remarkable achievements, groundbreaking insights, and relentless commitment to making positive impact in the world of endodontics and the world in general. He is a course lead endodontics assistant professor, adult restorative dentistry at Oman Dental College, Muscat. He's a PhD fellow from Bart's London School of Dentistry and Medicine, Queen's Mary University, London, UK. He's adjunct professor at Savita Dental College, Chennai. He's also certified silver member Style Italiano Endodontics, and he's a great clinician in the field of endodontics. I introduce Dr. Viresh Chopra. The stage is yours. Today we are gathering here. The primary reason being there are lots and lots of retreatment that are being done, but dentists do lack tools and knowledge and sometimes wisdom in which teeth to select for retreatment or which teeth not. So I give Dr. Viresh Chopra the platform along with my friend Oscar from Perfect Dental and on behalf of Orbit Life Sciences and Dentist Channel Online. Dr. Viresh Chopra will guide you and give you insights into the retreatment with Retreatity in endodontics and the facts that we need to know. Over to you, sir.
Thank you, Dr. Sanket, for such a nice introduction. Am I audible?
Yes, you are.
Okay. So, first of all, I would like to thank everyone who has joined this webinar for registering this webinar and showing your trust on us. And secondly, good morning from London, and good afternoon to you guys, and good evening wherever you are placed, according to that. I hope I can and we together can, give you the information which you need for retreatment and which you need for this kit retreaty and for which you have joined this webinar. So I really hope that I'm able to justify your time investment in this webinar. So without wasting time, I will share my screen and then we can start with this webinar. Please let me know if it is visible. Can you guys see the screen now?
Yes, it's visible.
Okay.
Yes, very
So,
clear.
right.
And I
So,
will
guys,
encourage participants to ask question answers in Q&A box. We will try and answer as many queries as possible in the limited time that we have.
e-
Thank you.
exactly. Thank you, Dr. Sanket. So, this is Oman Dental College where I work, and this is me in front of your screens, Viresh, and these are my affiliations which I have gathered till now, and these are the affiliations with the universities and dental schools around the world. And I'm also the editor of this book called as Clinical Atlas of Retreatment in Endodontics. Basically, this has a lot of clinical cases of retreatment and which have been performed by me as well as a lot of world renowned clinicians have put in their cases in this. So I encourage you, if you want to go through this book, you are more than welcome. I also happen to be a certified silver member of the largest online endodontic group and the most favored one, that is Style Italiano Endodontics. And it also has a website, Pop Dentistry, where you can see a lot of webinars conducted by their speakers and their members. So I welcome you all to enjoy this webinar. Also join Style Italiano Endodontics. So today we'll be talking about retreatment with Retreatity and the facts that we need to know about this particular kit, which is called as Retreatity, right? So now this webinar I have divided into two parts. in which first I'll be discussing about retreatment in general, the factors that lead to retreatment, the cases that can be selected for retreatment, and then I will be discussing about this kit in detail, which is RETREATY, the features that make it exceptionally a good kit, as well as the protocol that needs to be used with retreaty to successfully perform retreatment in endodontics. Now, how do we fulfill all these parts? What are the aims of this webinar? The basic aim of this webinar is to analyze different cases which require retreatment, gather information regarding what cases can be selected for retreatment and what cases cannot be selected for retreatment. And then when once we have selected a case for retreatment, how do we manage and successfully treat using this particular kit, which is called as RETREATY. But before I start with this, cases with retreatment, and before I start telling you about retreatment, I just want you all to remember these 2-3 points whenever you are encountering retreatment cases in your endodontic practice. Number one is, the first thing is, what we are talking about when we discuss retreatment is that the point of focus is failures, because the primary root canal treatment has failed, because due to which we need to do a retreatment on that. So what do we mean by failures? Failures basically is nothing, but it only means that somebody has allowed us to find an appropriate and intelligent logic and use that particular logic to reach endodontic success. So failure, whether in endodontics, whether in life, it is basically an opportunity for you to find where there is a lack with the primary treatment that has been done or the primary step that was taken earlier, and this time to cover that step to reach success, right? So always remember that. And when it comes to endodontics in particular, always remember that nothing is possible in the presence of microorganisms. Remember this point, that if there are microorganisms present in the root canal, then do not think that you will get success with primary treatment or retreatment. However, everything is possible in the absence of microorganisms. When we say in the absence of microorganisms, we do not mean to say that the root canal should be totally free of micro. However good we are, however good you are as an endodontist or a root canal specialist, nobody on this planet can make the root canal system totally free of microorganisms. Always remember that. But what we are trying to do is, by doing our root canal treatment or retreatment, what we are trying to do is we are trying to basically bring the quantity of microorganisms to a level where your body defense mechanism can take over and you can see healing happening. That is what the main focus is. So please do not understand by this statement that we are trying to make the root canal system 100% free of microorganisms, because we cannot do that. Now, coming on to the first aim of this webinar, that is, which I said, that we will analyze the various reasons for root canal failures. And we have a lot of articles. One of the master articles is basically that analyzes the cause of failure in non-surgical primary root canal treatment, which clearly says that the major reason for failure of primary root canal treatment are leaky canals, which can be under-obturated, over-obturated, inadequately cleaned and shaped, instrumented, or there is a missed canal. Missed canal is basically uh, maybe due to lack of magnification. And when we say magnification, it doesn't mean only microscopes, it can be loops also, because I believe that even if you are using basic loops, not an expensive one, but a basic loop, at least you can visualize your excess cavity very nicely, which can help you to find the missing canals, right? So these are the number two factors that are the top of the charts for your failure in primary root canal treatment. Other factors that basically literature cites is in front of your screens, which are perforations, instrument fracture, missed canals. As I said, it is at the top of the chart, under obturation and over obturation. And all these factors basically what they do is they basically come together to form an umbrella that is known to cause failures in root canal treatment. But how do they cause failures? They basically do not allow us to do proper cleaning and disinfection of the root canal system. And when we are not able to clean and disinfect the root canal system, definitely, as I said previously, there are microorganisms which are left behind, and they are left in good quantity, because of which microbial infection happens, and because of which the root canal treatment that we had done, it fails. Right? I hope I'm able to make you understand that simple channel how a root canal treatment fails. Now, to me, these factors do not directly cause failures. They only become a reason for not cleaning and disinfecting the root canal system properly. So what is causing a failure is basically caused by inadequate cleaning and disinfection. So for some reason, if I am able to take care of perforations, I am able to treat instrument fracture, I can locate missed canals, I can take care of the under obturation or the over obturation, then probably I am cleaning and disinfecting the root canal properly, and chances of failure become less. So we need to change our bent of mind that even if we encounter a case with a perforation, we need to understand that yes, seeing all other factors like the periapical area, the periodontal stability, and everything, we need to select the case properly, and then understand that if I treat this perforation properly, nicely, I seal this perforation or I remove the instrument from the canal, I'll be able to clean and disinfect nicely, and probably the failure will turn into success. So we need to have this bent of mind. One thing more we need to appreciate, whenever I have talked to many people while discussing, the root canal treatment, I have always encountered that we were treating this root canal and it failed and this happened, that happened. Please understand that we are not treating root canal here. We need to give that respect to the tooth and to this but a whole arrangement, because this arrangement is not about a single root canal. It is basically about a root canal system, because when we say a root canal system, this means that we are actually appreciating the various complexities within this root canal system. And when we appreciate those complexities, this means when we are treating it, we are also taking care of treating that particular complexities also, like lateral branches, like anastomosis. I understand we cannot take care of them with instruments, but we can definitely take care of them with our irrigation. So we need to devote our time to the irrigation and treat the root canal system rather than treating root canal only. Now let's see this case. I will start with a simple case of retreatment. Let's see this case. I'm talking about the six, that is first molar. The patient came to me with a chief complaint in front of your screen that RCT was done around 6 months back. But since then, the patient is continuously having sensitivity to hot and cold. And again, she is speaking about a particular tooth. She is not talking about a particular area. She can actually put her finger at the first molar, and she can actually tell me that this is the tooth, not the behind tooth, not the front tooth. Whereas you can see there is a evidence, X-ray evidence, pictorial evidence that shows that there is a short obturation in a premolar. However, the obturation quality in your molars look to be adequate enough, look to be satisfactory, but still the patient is having sensitivity, right? So in this case, we have read in evidence that pulp vitality test should not be done on a root canal treated tooth, but which is fair enough. Yes, why to do a pulp vitality testing in a root canal treated tooth where there is no tissue? However, in this particular tooth, patient is complaining of hot and cold, and she is as sure as she is sure that her name is this. So she is as sure about this particular tooth. So this means that there is a presence of biological tissue in this particular tooth. But the evidence says we should not be doing a vitality and sensibility testing. That is what evidence says. But if I perform a vitality testing on this particular tooth, am I doing really wrong on that? Or am I being invasive? No. So I don't think so that I'm taking a something doing a very wrong step by doing vitality. I'm just testing it. I am not cutting the tooth. I'm not doing any invasive treatment. So going against the evidence, I end up testing this tooth for a vital tissue. And what do I get? I get a response. No response on a premolar, no response on the second molar, but I get a response on the first molar. And this encourages me to think that the quality of the obturation looks really nice and it's a first molar. So great chances are there that there is a missed canal. And I refer the patient for a CBCT. I understand that it's not very easy to convince the patient for a CBCT in different parts of the world, wherever we come from. However, we can always take a few X-rays on different angulation that might reveal some detail to us, right? But this, if we hear properly, if we hear the complaint of the patient properly, many times we are able to diagnose from there only. And the complaint here itself says that there is biological tissue and first molar connected with the scientific literature evidence. So first molar is generally associated with missed canals, right? So I send the patient for CBCT and see what we get on CBCT. If you see this part, we have a missed canal here. And if you see this screen on this CBCT, clearly there is a missed canal outline we can see on this CBCT. So what do I do? Do I treat the whole tooth? Because sometimes when we are treating such a decent tooth, decent obturated tooth, we can cause apical periodontitis to the patient, acute apical periodontitis, where the patient can complain of more pain. So I go for something which is called as selective root canal treatment, where I will only dig a window in the mesiobuccal area, because MB2 is the MB1 is MB2 is the most common missed canal. So I'll be digging only that area and I will try to find a soft spot in case it is present, trying to be as minimally invasive as possible. And to my luck, when I put my DG16 Explorer, I am able to see a soft spot, as you can see on the screen. Right. So this means that there is a missed canal lying there. I don't need to make the complete excess cavity. I don't need to destroy the whole tooth. Let's stay minimally invasive. And the moment I find this, I place a 10K or a 15K file depending upon the patency to whatever point of resistance it is going, and I shoot a radiograph. When I shoot a radiograph, I see that the file is going inside and I see the length to which it is going. When we take out the file, always take care to see on the flutes of the file whether you are having any traces of gutta percha or you are having any traces of sealer. Because if you are having these traces there, this clearly means that MB1 is meeting with MB2. But if you do not have these traces, this means that they are separate. So if they are separate, it becomes really easy for us to treat this case. So I do an initial cleaning and shaping with a 15K hand file. I do that cleaning and shaping and I send the patient back home. That very evening, the patient says that, doc, what you have done? I am not having any sensibility now. I drank hot, I had cold water, I'm not having any sensitivity. So this means that biological tissue has been removed to whatever little extent we could in the first visit, and it has given relief to the patient. So that particularly shows that we are on the right track. So the patient comes in the next visit, isolated. The root canal retreatment becomes a normal treatment. You can see on your screen, just clean and shaped like a normal tooth, normal canal, taking care that at no point you, at every point you are verifying that your MB2 is not meeting MB1. So once we are clear, we clean and shape according to the rotary protocol. Once it is finally cleaned and shaped, we use sealers and we obturate with gutta percha as the core material. In my practice, basically 90% of the times I'm using bioceramic sealers because I like the way they are injected inside and the properties of bioceramic sealers. It doesn't create any mess in on the tooth. It fills the root canal system properly, and then I place a gutta percha inside and I sear it off. You don't need to coat the gutta percha also for with the sealer because the root canal is already filled with your sealer here, and you sear it off with a heated plugger. It's not a very complex procedure. It's a very simple procedure to be done provided we stick to the protocol of how it has to be done. And you can see here, simply laterally moving the endodontic plugger, it is getting seared off. I don't have to do. And then in the end, this is what I am getting, and the patient is relieved of the symptoms and the job is done. So this is what is called as selective root canal retreatment rather than going into the complete invasive root canal retreatment. So now when we do this, I basically don't call it as a re-root canal treatment. I call it as a C root canal treatment, which I personally call it as a C concept. This is my own term, and I call it as a C concept, which means that I am doing a CRCT rather than doing a re-RCT. And this CRCT terminology means that I am doing a corrective root canal treatment rather than doing a re-root canal treatment because I'm just correcting the mistake here. Once I've corrected the mistake, the root canal becomes like a normal treatment for me, and I just follow the protocol and it is done. And I believe that if it can be done by me, it can be done from all of you who are on the screens present here. Now, when we talk about retreatment in particular, we always fight with what systems do we have to do a retreatment because we want our retreatment to be predictable and easier. I'm not sure that how you all start with retreatment, but in earlier days when I used to do retreatment, I always used to start with hand filing first to take off little traces of gutta percha, and many times while doing hand filing, my hand file, stainless steel file, used to break inside, and it used to create a more complex situation for me. So we decided that we need a system that where retreatment can actually start with rotary files rather than going with your hand filing. So this is what the basic thought was, and then we needed a system which is according to the ideologies of our group, which is called as Style Italian or Endodontics, who believe that every system should be teachable, feasible, and repeatable. This means we are able to teach you properly. You should know that it is feasible, and then once you learn it, you can repeat it again and again without having any problem. So this means it should have a simple protocol of doing that. So when all these three ideologies came into the picture, then Style Italiano, along with Perfect Endo, created a system which is called as RETREATY, and it is actually represented by these figurines which you see on the screen, which look really interesting. And I generally call it, perfect endo people know that I generally called it as the Avenger system, right? It is super efficient, and I'll show you why we say that. Now, every figurine here has a name, every file has a name, and these are the names right in front of your screen. We call it as a bull, we call it as a skinny, and then we call it as shape 1, 2, and 3, right? Depending upon which step you are doing. We start the retreatment with the bull file here. And if you see on your screen properly, you will see that it is a set of 5 files, different colors. So this means that one set, a simple set of 5 files you have, which has 3 alloys in it. That is why the files are of different colors. So there is no set available which gives you a combination of 3 alloys, because we know that the gold alloy has its own advantages, silver alloy has its own advantages, and the blue alloy has its own advantages. And we combined here the perfect endo along with style Italiano endodontics. They combined all these 3 alloys to give one complete system, which where the dentist can enjoy the advantages of all the 3 alloys following a single protocol. And that is what we call it as a perfect system till date. This system, basically, if you see on these screens, these are the files which are present. The shortest file is the bull file, and it is the widest file. You can see it is 25 ISO number with a 0.07 taper. The speed with which you have to use these files is right in your screens, and all use the same top. So you don't need to get confused that which file has to be used at what speed and what top. So you can use all the files between 350 to 500 RPM, and you can choose a single torque that is 1.5 Newton per centimeter and use that. Right. So this is a simple system to follow. Each file has its unique feature. Like if we talk about bull here, it is the widest file. If you see the morphology of these files, which is right on your screen, it looks more like an H file. But what happened in H file was you have an H hand file. It is a very weak file. Very commonly, it will fracture inside the canal, right? Because there is no core strength available inside the file. Though it has a edge pattern, headstrong pattern outside, but inside there is no core strength, because of which it was really easy for it to break at any of the junction of the spirals. However, this file has a core strength inside, core material inside, which makes it strong, and that is why it is named as bull, because it is very strong. It can also be used for mechanical pre-flaring of the mist canals. Even if there is not a gutta percha, you can actually use it for pre-flaring, like your orifice shapers, right? Removal of only coronal gutta percha. You do not have to take this file to the full working length. Please do not push the file. Whenever you are doing endo, do a passive endodontics. Do not push the file thinking that little one more millimeter, let me push. Don't do that. And the best part of these whole kit files is that they can be used in continuous rotation as well as reciprocation. So if somebody does not have a reciprocating motor, not a problem at all. You can actually use it in a continuous rotation. If somebody has a reciprocating and they want to use it in a reciprocating manner, they are free to use it. This file is shortest in the kit, that is 21 millimeter in length. Please do not push it to the full length. And this has a safe ended, semi-safe ended tip, as you can see, which will guide it along the root canal. The advantage of semi-safe ended tip is that it does not deviate the original shape of the root canal. When you are doing a retreatment, I'm not talking about a primary root canal treatment, I'm talking about a retreatment here. When we are doing retreatment, many a times you will see that the root canal anatomy is already damaged. Either If it's an obturation, the apical foramen is big or the root canal is straightened. Somehow there is a damage to the root canal shape and morphology in that particular tooth where you are doing a retreatment. So you need a file or a file system which does not deviate that particular shape. So this is a semi-safe ended tip, and you can see on your screens, and it is a bulky file, and that is why we also call it as a gutta eater. That once we place it inside the root canal, it just rotates and takes out the gutta percha. You will see as I show you the cases. So you have to use it in the coronal part. Do not take it to the apical part. And if you are using in a continuous rotation motion, we advise that you use it at a speed of 400 rpm. But in case you are using at a reciprocating way, then you should be using an angle of 30 degrees anti-clockwise and 150-degree clockwise. So these are the recommendations from our masters and us from Style Italiano Endodontics. Second file is your skinny file. The advantages are here. It has to be taken to a mid-root level where it can take out the gutta percha. Reshaping of the coronal two-third can be done, and it has enhanced cutting efficiency. What do we mean by that? If you see clearly the file on your screen, it is a number 2504. This means that you were using bull, which was number 2507. It has already widened the coronal orifice. Now this skinny is coming inside, which is thinner than the bull. So it will be very easy for it to go inside. If you want to reshape your coronal two-third, then you need to grind it along the walls of coronal two-third. Otherwise, it will not be shaping the coronal two-third again because it is thinner than the taper that you have already provided. You have already done the pre-flaring, and it is a flexible file, so it will glide along the gutta percha. And other advantages of these files are right in front of your screens, which say that it's a silver alloy, ideal for a glide path because it is thin, great cutting efficiency it has, and it has a semi active tip as like your bull. Sorry. Coming on to the third file, which is shapy minimally invasive reshaping file. It again removes the gutta percha from mid root level, and you can slightly take it to the inside the apical part. You can introduce it subtly to the apical part. That is why these are called as the shaping files. Though they are retreatment files, but the bulk of the gutta percha has been taken out by your pull and by your skinny file. Now they will start shaping, but at the same time, owing to their morphology, which is still sticking to your edge headstrong morphology, they will be taking out the residual gutta percha from the apical part and the mid-root level. They have high cutting efficiency, high fatigue resistance. Reason why they have high fatigue resistance in comparison to other retreatment files is because they have a bulk core material inside. They are bulky files. At the same time, because of the gold treatment that has been done on them, they are flexible files. Thin because the taper is 0.5, great cutting efficiency, and because of their semi-safe ended tip, they follow the root canal treatment. So these features that have been given in these files are very carefully crafted so that the dentist can enjoy an easy protocol with them without thinking that this system will change the shape of the root canal, or if you are using the file for the first time or the second time, then you will be breaking the file inside. It doesn't happen with them very often until unless you as an operator or we as an operator we insult these files and overuse them, then definitely any file will break. Coming on to the shapey 2, 2505 again. So O5 is the minimum taper here. O7 or is the widest taper where corner pre-framing was done with the bull. O5 is the minimum taper that is given from apical to middle and to cornal. So cornal is O7, middle and apical are O5, because of which there is a continuous taper that comes which we require for a three-dimensional obturation. So the advantages, again, this is a gold treatment, resistant file to fracture, can be used in continuous rotation. It is very efficient in debris removal. As I said, it will remove your residual debris inside the root canal. At the same time, it is minimally invasive in shaping the root canal system because of its taper. Now, the last file that is coming in this system, it is one of my favorite files, maybe because of the color or maybe because of the character here, which looks to be a little very rusty character, right? It is a number ISO number 3005, but we only use it if we require, if we feel the need of, if the canals are little wider, or we need to enlarge the apical foramen to 30 size. As I said before, majority of the times when you are doing retreatment, majority of the times the apical size of the root canal system is already damaged. It would be wider than what you are thinking if it is a over obturation, or even if it is a obturation up till the apical foramen but it has failed for some reason, right? So it is already damaged, so you will have to majority of the time introduce this file. And this file, you can see, is made up of blue alloy. Now blue alloy has an advantage other different from your gold alloy as well as your silver alloy, like other files, right? The tip is used for apical enlargement. You can see the tip, it is safe ended, not semi safe ended, right? Like other file, you can see this change in the shape of the tip. It is safe ended tip so that it doesn't cause any transportation. Because of the blue alloy, it becomes more flexible, you will see in cases as I show below, and it respects the root canal anatomy by not changing the shape of the root canal. Now this is the blue file by which I was talking about, and you will see how flexible it is. Though used for apical enlargement, still it stays in that shape, because of which it does not change the shape, original shape of the root canal anatomy, at the same time maintains its cutting efficiency. Now let's see what is the protocol of using these files when we are performing retreatment in endodontics. Let's see this case. Now, generally what we do in a primary root canal treatment is that we divide the root into three parts. That is apical part, middle part, and the coronal part, which is fair enough, right? But when we are doing retreatment, we are already into a complex situation. So what we need to do is, rather than directly concentrating on the root canals here or the roots here, first we need to see the coronal part, that how we need to enter inside the root canal. Now, when we talk about the coronal part, this means that we are planning our retreatment properly. Now, in this particular case, how do we plan that? Yes, when we start retreatment, we first have to remove this restoration, make an access through this restoration. Then, in a primary root canal treatment, what we try to look is first the drop, second is the dentinal map. I hope you all agree with me that we look for the dentinal map, which tells us the path to the other canals. But here, we will not feel a drop because it is gutta percha here or a restoration. Second is we will not have any dentinal map. So what we need to see is the moment we go take our burr inside, we need to feel the tactile sensation where we are not cutting hard restoration. Suddenly we are touching the gutta percha. The moment we feel that or we reach that depth, we need to locate the gutta perchas, which will be pinkish in color. So we need to locate the gutta perchas and then slow down our cutting. we may have to shift to hand instrumentation, or we may have to shift to ultrasonic instrumentation where we need to remove the excess of gutta percha. Now, when I say ultrasonic instrumentation, I totally agree that we all do not have endodontic ultrasonics, but at this level, we can actually use our perioscalar tips also. Because the moment we use our perioscalar tips to modify the excess cavity or to cut gutta percha, we will see that gutta percha is getting heated and coming out. So we remove the bulk of gutta percha from the pulp chamber, and then we will get the orifices, pink color orifices, how much ever they are filled. If the three are filled, we'll get three dots. If we have two filled, we'll have two dots depending upon the number of root canals. So that is how we plan our retreatment. So let's see, once we remove the restoration, how we locate the gutta percha and how we remove the excess of gutta percha, and then we use the retreaty sequence as per the protocol. Now, if we see this video, already gutta percha is located. You can see the dirty mesh created here. Now, the moment we are able to locate the gutta percha, we widen the excess cavity. Sometimes if it's an amalgam restoration, metallic restoration, it will just pop out as a complete, as happened in this case. Isolation is the key. Please try to isolate. Try to look for any missed canals. Hand instrumentation, do not hurry. Please do not hurry if you are doing endodontics, and more so if you are doing retreatment. Try to just locate here. We are not trying to see patency. Once we have located the canals, modify the excess cavity with ultrasonics. We generally use endo ultrasonics because you can see we only touch the areas where it is required with endo ultrasonics. With burr, sometimes we do not know where all we are touching. It is a very conservative touching that is happening. Minimally, we are broadening section wise, that okay, now mesial area, now distal area, cutting, not cutting the whole excess cavity in one go. And once we have located the canals, that is when we pick up the retreaty sequence. You can see here, and you can see the bull file, that is the first file, gutta eater, actually going inside the missed mesiolingual canal and doing a pre-flaring of the canal. There is no gutta percha inside. Pre-flaring of the coronal part of the missed canal is happening here. So that is what I told you, that this file can be used for pre-flaring, and you can see debris coming out by the virtue of this design of this file, headstrong design. These files throw the debris or gutta percha, residual gutta percha outside the canal, as you can see here happening on the screen. So we do not have to worry about that the gutta percha will be pushed beyond in the apical part. It throws the gutta percha out because between these spirals there is good evident space, flutes that are giving inside, radial lands are there from which the gutta percha and the debris basically climbs up. So then once this is done, once the coronal part is flared, we introduce skinny there. You can see skinny is not touching the coronal part, but it is removing gutta percha from the middle part, and the conservative shaping is happening along the gutta percha removal. Irrigation, please do not work in dry canals. Never work in dry canals. Always keep the canals moist. Once you have removed the gutta percha, now this is the time to do a working length as per the protocol, right? Apex locators if you are using, or the radiographic working length. And once it is, the gutta perchas are removed by using skinny as well as with using gutta eater or the bull file, now is the time to shape the file and remove residual gutta percha if there is any. So after working length has been taken, now we do a full length shaping using the Shapey 1, Shapey 2 and Shapey 3 files here, right? As per the sequence. If, as I told you, that we can end the cleaning and shaping at Shapey 2, but in case if we feel while working that the apical enlargement is required and already the canal is apically enlarged, and it will be insufficiently cleaned if we end or stop at Shapey 2. Then introduce your Shapey 3 because it is the apical enlargement file. Once you introduce your Shapey 3, you are adequately performing the apical enlargement and preparing the file to receive gutta percha and your three-dimensional obturation. Continuous rotation, you don't see any reciprocating rotation happening here. It is the files can be used and continuous rotation from a speed of 350 to 500 rpm at a torque of 1.5 n per cm. So you can see debris coming out clearly. There is no uh, force required while using these files. Easily the debris will climb up the file by virtue of its design. The file, the debris is coming up, and then you irrigate and clean. Once they are finally cleaned and shaped, we are ready to perform obturation here. So this is the simple protocol that these file kits offer us. We told you we use bioceramics. Simply fill the canals with bioceramic sealers, gutta percha, and do a heated cutting or a warm vertical condensation if you want to do that. So once this is done, the canals are shaped, and you can see here divided the sequence used, the gutta eater and skinny used till coronal and middle third, which you can see. Then working length was taken, and then in the second visit we had introduced our Shapey files, Shapey 1, 2 and 3. So the case which came like this was performed successfully with RETREATY, and this was the final result of this case. So probably these are the system which give an answer to a predictable and easier retreatment protocol. So that is why we welcome this retreaty sequence with open hands, because it is very easy to use, and actually retreatment can be used started directly with your rotary systems. And the most important part here is, which you will see in this case also, that you do not actually require the use of solvent to melt gutta percha when you are using gutta eater, that is the bull file. When you are using that file, you do not need to use solvent. Many a times we needed solvent when we were using hand file to soften the gutta percha. However, with the core strength of this file, the gutta percha all automatically gets heated. If it doesn't get heated, you can actually use your perioscalar tips to just give some heat to the gutta percha and introduce this file, as you will see has happened in this particular case, where removal of restoration was done. As I said, you need to plan your retreatment. Removal of the restoration is done. Then you locate the gutta percha. Once the gutta percha is located, you use scalers, endoscalers or perioscalers to modify your excess cavity. Number one, that is minimally invasive modification of the excess cavity required. And then also to give heat to your gutta percas, either with endoultrasonics or with your periultrasonics, and remove the gutta percas efficiently. Ideally, there should be no gutta percha in the pulp chamber. When you are obturating, the obturation should actually be only limited till the orifice. However, if we are not able to do that, kindly the pulp chamber should receive only your uh, restorative material. Now, this is where the heat is being given, because it is covered by sealer also. So heat is being given to the residual gutta percas, and gutta percas are real little heat. With heat, it softens a little, and once it softens, you place the head of bull, the tip of bull, on the heated gutta percha and just introduce the file inside at the recommended speed. And once it is introduced, you see the file itself removes the gutta percha and throws it outside the canal. You are seeing in front of your screens. It is taking the bulk of gutta percha out of the canal without performing any pressure, without using any force. We do not have to use force while doing retreatment. Ideally, even while doing primary root canal treatment, no force needs to be used. And once you have removed the gutta percha from the coronal two-third, we verify that, locate the excess, explore the excess cavity for any missed canal, and then introduce a skinny file which is thinner than your gutta eater or the bull file. Once we introduce the skinny file, it removes the residual gutta percha from the root canal. At the same time, it shapes the root canal, and then this retreatment becomes very easy, like a primary root canal treatment, thanks to these files. So you can see a primary root canal treatment, like a primary root canal treatment usage of these files. Slowly and steadily, you can see if any residual gutta percha. You can blend the use of hand files as well as these retreaty files. And once this is done, it becomes like a normal root canal. You obturate and perform the root canal treatment. However, when you are using this particular system, please remember these key points, which says that you need to frequently clean the spires. Whenever you are using this system, kindly please clean the spires and then reintroduce this file. Otherwise, if the file is already loaded with gutta percha or debris, then it becomes easier for this file to separate inside because it is loaded and stresses will be generated on this file. Check these files for distortions or wear on the file. Reason is because when you are doing retreatment, already the stress level is higher on the file because it has to shape. At the same time, it has to remove the hardened gutta percha from inside. It is removing a solid material. The stress levels are high, so it can might get distorted depending upon the type of case you are handling. So please check the file after every use. Irrigate frequently and abundantly, whether you are doing a primary root canal treatment or you are doing a retreatment. Never work in a dry canal, please. Always keep the canals moist because they help in reducing the friction and reducing the stress on the instrument. Follow the advised settings. Don't decide the settings on your own. Even if you are using a endo motor from Perfect Endo, which is ZR Touch, it has its settings for retreaty also, and it's a very pocket friendly motor. Means in terms of expenses, it suits our pocket, and it's a very reliable one. I have been using it for the I think last 4 years, and I've never had any complaints from it. You can use all the systems into it with this retreaty sequence also. Start the procedure after scouting, right? Once you have removed the gutta percha, always see, as I said, there is no shortcut to the protocol. We have to follow the protocol whether you are doing a primary root canal treatment or you are doing a retreatment. So once you have removed the gutta percha, always scout the canal with your hand filing. See the canal patency, how it is. It may be very nice, it may be very smooth, but it is always good to check it and then continue to the shapy files and work with plenty of irrigation. There is no shortcut to irrigation because, as I said, that you are not treating a root canal, you are basically treating a root canal system, and majority of the complexities are taken care by root canal irrigation rather than your instruments. And always apply soft pressure. Do not use any force while using rotary instruments inside the canal. The moment you use force and you are not using pecking motion, you are moving towards file separation. So kindly please take care of these files. And even if you are handling complex cases which are obturations with thermophil, you can, which is a carrier based obturation, you can actually use these files in that particular cases also. Like you can see on the screen, you can see therma carriers here inside on the mesial canals. Again, endo ultrasonics are being used to modify the excess cavity and the orifices a little. Once we are sure that we have removed the whole restoration and gutta percha, introducing gutta eater, removing the gutta percha from there, and even introducing gutta eater in the thermophil root canal. See here in the coronal part, once the thermophil is loosened, the carriers are loosened, you just remove them with your spoon excavators, which are of these minimal invasive spoon excavators we are talking about here. Remove it with your hand instruments and then introduce your skinny file here, because the bulk of the gutta percha has been removed and coronal pre-flaring has been done with your bull file. Once you have removed your skinny, we are again going into, shaping files as per the protocol. Irrigate profusely, abundantly, never work in a dry canal, and you will see the residual gutta percha coming out of the canal along with these files. Evidence says that there is very minimal debris that gets pushed beyond the apical foramen with these files because of the design of these files. Right, you can see most of the residual coming out. Then you are introducing the apical enlargement file. Majority of the retreatment cases, you will see that you need apical enlargement file, and once it is done, using a sealer, gutta percha, and then searing it off at the orifice level, obturate the canals. Irrigation is the key to primary root canal treatment or a retreatment to have success there, along with three-dimensional obturation. No shortcuts. The more thermophil is coming out, because sometimes, yes, we all know that the gutta percha or the carrier based obturations, they remain stuck. Obturations are done, sealer is applied here. That is why we like using injectable sealers, because we know that we are filling the root canals here and we are not assuming that the root canals are being filled with sealers, right? When we are using rotary systems or we are using lentillo spirals, we actually end up assuming. But here we can see what is happening and we know the obturation is happening along with the sealer. It is filled properly and the root canal is done. Not only in posterior teeth, these systems can be easily used in anterior teeth only, where you re-enter the excess cavity using a round burr or a tapered burr. Here on the screen, you can see a minimal invasive cavity being made by round burr only, no use of tapered burr, because it's a single root canal and probably the clinician feels that it is easy to enter there. So majority of the times you stick to the protocol, but at the same time, it is a clinician's decision, right? These files are best used with Zeta Touch. If you can see on your screens, the Zeta Touch already has a setting which are incorporated inside the motor for every RETREATY file. It's a very dependable motor, and it is cost effective also. So what else do we need? We have a good file system, we have a motor which gives us the best of both worlds, that is expense also and reliability also. So this system can be very predictably used with these rotary motors here. Now, if we do not have something called as straight line access, or we are having, facing some challenging root canal anatomies, or we are using overused files, or we are using forces during root canal shaping, there is something called as instrument separation that happens. And I know that we all fear instrument separation, because this is one phase which basically lands us into a uh, area where we are not able to say anything to the patient. We cannot blame anything on the root canal anatomy, and it directly points at our inefficiency. So we have evidence that there is high incidence of root canal instrument separation while cleaning and shaping. This is not a small number, 66 to 78%. And why this happens is because the apical part of the nickel titanium instruments that we are using, that gets engaged in the apical part, and the motor is running coronally where it snaps because of the torsional fatigue. So we need to appreciate and we need to realize that we don't need to overuse the instruments and stick to the protocols. The most common teeth where these instruments fracture are basically molars, and that too, out of molars it is mandibular molars, because the most common most difficult root canals to be treated are the mesial canals of mandibular molars because of the access that we need. Since we do not have a straight line access to that those particular part of the canals, majority of the instruments, they undergo stress, and when we are using them for the second or the third time, they eventually many a times break also. Right. So we need to understand that how to use these systems efficiently, and we need to discard if the file has been used for 3 to 4 times or two to generally all rotary systems, they say that it's a single file, single use system. Yes, they are right. Right. But if in case somebody is using them for the second or the third time, kindly first note the type of root canal you are shaping. It should be easy. It should not be calcified canals. And then check the files that you are using. Right? They should be in good condition. If there is any evidence of wear and tear on those files, kindly discard them. The good news is that even if file separates, we have different ways of removing the file. But let's see that in certain cases why the file separates, where we go wrong. First is if we do not have a straight line access. These days lot of excess cavities are coming into the picture. People are following the fashion, they are making truss preparations, they are, I don't know what all, but I am not a very big fan of truss preparations. I am a fan of straight line access and minimal invasive excess cavity. But when I say minimal invasive excess cavities, I don't mean to say that we should not be having a straight line access. There has to be a balance that needs to be created so that we minimally destroy the tooth. At the same time, we have a straight line access inside the root canal system. Now, this case was referred for a root canal treatment. The dentist had tried to access the root canals, but he could not locate the canals, which is very understandable. We are talking about molar here. You can see on the screen, it is a calcified root canal system. And if I try to read the radiograph properly, the radiograph itself says that the pulp chamber is completely calcified. It is obliterated with maybe a movable pulp stone, maybe a attached pulp stone, but it is obliterated. So the first sign of caution to me is that when I am making and re-entering it, it will be difficult for me to feel a drop. I will not feel a drop. So I will be encountering a hard tissue everywhere. So I have to be slow and observe again and again. Right. And what we do in an ideal excess cavity preparation, when we are making an excess cavity preparation, how do we get a straight line access? We basically get a straight line access by following the outside outline of the pulp chamber. Right. I hope you all agree with me. We follow the outside line of the pulp chamber, and that is what I have done here. So I re-entered the system. I re-entered the pulp chamber here. You can see an initial access, and you can see here the whole pulp chamber. The floor you can see is of pulpal stone, attached pulpal stone, which is not ready to move, which is very much evident from the radiograph. So we use ultrasonics to modify. You can see here, this is for demonstration purposes. I am using a perio ultrasonic here so that I can tell you that yes, we can use peri-ultrasonic for modifying excess cavities. Here I am using it without water because I don't worry about patient being in pain or pulp getting damaged. Patient is under LA, totally asymptomatic. Already I'm doing for a root canal treat. I'm going for a root canal treatment, so I don't need to worry about pulp getting damaged by the heat, right? So when I don't have complaint and I don't have to worry about the damage of heat, I can easily use it without water because it will give me good vision. However, if I am using the same system with water, my vision will get hampered. As you will now see on the screen, that is, as I said, it is for demonstrating purposes. So I use this with water also, and the vision gets hampered. So it is always better to use ultrasonics without water so that you can know which surfaces you are touching, where you are cutting, and you modify the excess cavity accordingly. So this is what is happening with water. I can't see anything. So I generally don't prefer to use water while doing. So now here I am using endo ultrasonics, going back to my protocol of modifying the excess cavity, and I achieve a straight line access. So once I achieve a straight line access, as you can see here, I have followed the outline wall, right? We have followed the outline wall. As I follow this, I reintroduce my rotary file here. Now in my practice, I am using new files every time. I do not reuse the files, right? So I open a new pack after putting my 10K file inside. I check for the canal patency. I know the file, the canal is little tighter, but the 10K file becomes a little loose after initial shaping. So I go with my normal protocol of rotary system, and the moment I use my new file for the very first time and take it out, this is what I get, right? Instrument separates there. Now I first is that I need to tell to the patient that instrument has separated, which I told, but I told the patient that don't worry, I'll take it out, but I need to understand why it happened, right? Now, if you remember, there is a high pulp stone. So this means it's an attached pulp stone. The pulpal floor, the inside wall of the root canal has become higher. So in such cases, we do not only follow the outline wall, we also follow the inside wall. And I had to widen the inside wall also, so that my instrument does not encounter any stress at the coronal part because it has fractured from the coronal part. So what I need to do was to open it coronally. Now, this is a slide which I'm showing you here, which I follow in root canal treatment, retreatment, as well as instrument separation. See this, how they catch the fish, how eagles and vultures they catch the fish, the good coordination between hand, mind, and eyes. The claws open, head goes down to see the prey. Once they catch the prey, fully concentrated, once they catch the prey is in their hand. That is when they move their head. See again. So this means they are not assuming, they are actually looking. So guys, vision is the key here. You need to look what you are doing. Don't assume. The moment we start assume, we are making a fool of ourselves here. So we need to look what is happening, and under the microscope when we see the instruments, the fractured instrument looks like this, triangular cross section, yes. And I widen the coronal part, introduce the BTR pen here. You can see introducing the BTR pen. Once the instrument is loosened with endodontic ultrasonics, the loop of the BTR pen is used to catch the neck of the instrument and pull the instrument out. No force to be used because the instrument is already loose here. Because if I am using excessive force, the loop will break because it is very delicate. So once I am catching the instrument, this is how the instrument comes out once it is caught with the loop. and the root canal mishap that had happened, it is taken care of, and it becomes a primary root canal treatment for me. So now from here, I take you back to my first slide where I said the different factors are there for causing failures. So I have taken care of this factor, and now I'm by modifying the excess cavity to have that straight line access and taking care of the factor here, taken care, root canal instrument is removed. So it is easy for me to perform the further steps of the root canal treatment as per the protocol. Right. So this is what I said. Failures do happen, mishaps do happen. But if we take care of them, then we can come back to the same journey and continue from where we had left. Right. So with a higher pulpal floor, with a attached pulp stone, four canals are found in that particular tooth, and obturated. When I said the pulpal floor should not be receiving this particular system, the pulpal floor should not be receiving the gutta percha here. This is what I meant. That gutta percha should end at the orifice level only. Right. So pulpal floor should not, pulpal chamber should not be having any gutta percha. So the patient that came to me like this, and which I made like this, because of probably my negligence, right, of not reading the radiograph properly. But the good part is, in the end, I finished the treatment like this. So when the patient went, calcified canals were taken care of, instrument separation was taken care of. So it's not about what you are facing during the journey. It's about how you are, how your attitude is towards those problems, and how you tackle those problems to terminate your journey successfully. So people who say that, oh, it can be done only with microscope, I would tell them that there are certain cases which you can do with loops also. As you can see on the screen, this is what I'm doing on a in a student clinic where I'm using loops. And till from, if you are able to see the instrument in the coronal part with the loop, you can actually use these instruments to take out and handle endodontic mishap under loops also. So guys, when we talk about magnification, it is not that we are only talking about microscopes. I understand they are expensive, but I started with using a Chinese loops, right, which were good quality but pocket friendly. So I would encourage that if you can use loops to better your dentistry. In the end, I would just like to say this is the take office message, that every case is important, but while performing retreatment and root canal treatments, please have patience, give attention to the detail, read the radiograph properly, question yourself, and plan your treatment. Whether you are doing retreatment, whether you are doing a root canal primary treatment, but please plan your treatment and keep yourself ready for the day where you know which system you are using. And if possible, try to use this system retreaty for retreatments, and you will see the difference. You will yourself see the difference, and then you will understand that why we are vouching for this particular system. I know we all want to do good dentistry, we all want to earn money, and we all want to have a good space in this world. So this is for everyone who is feeling lost, because that was I was at a position where I used to feel lost, that what should I be doing, right? And this is for everyone. Enjoy this video. I hope you enjoyed this video and it gave you the right message which I wanted to give. And if you want if you have any questions, though I'll be answering them here in on this platform after we finish this webinar. But if you have any further questions, you can contact me on these social medias. And if possible, go through this book. You will see ample number of cases, and you will be able to relate them with your clinical practice and see the tips that are used to treat those retreatments in endodontics. In the end, I would like to thank Perfect Endo, Dr. Sanket, and his team for providing us all with this opportunity to talk about Retreaty here and talk about the advantages of this system and see and learn how predictably we can use this system to achieve success while doing retreatment. I hope you guys have enjoyed this and you got the correct message, and I hope that you enjoyed doing retreatments with this particular system. Over to you, Dr. Sanket. Thank you so much, guys.
Thank you, sir, for such a wonderful, wonderful session. It was indeed a pleasure listening to you. So there are around 14 questions, well, which I have tried to answer at my level the best. But some of the questions I would like to put forward is, which endodontic tips are you using at present? Is one of the question by the attendees.
So,
The ultrasonic tips.
endo ultrasonic tips. See, I don't do not stick to any single endo ultrasonic tips. I have endo ultrasonic tips from Spartan Opera company. I have endo ultrasonic tips from Dentsply. So it's not a very particular endo ultrasonic tip I'm sticking to. And if I'm doing a retreatment, I sometimes I use Yoshi Darwachi's retrieval kit and ultrasonics in that, and then I use BTR pen for removing instrument. But majority I use combination of endo ultrasonic tips.
What irrigation protocol do you follow during the retreatment?
See, irrigation protocol remains the same whether you are doing primary root canal treatment or you are doing a retreatment. You use 2.5% to 3% sodium hypo. You use final rinse with sodium hypo, then EDTA you are doing, right? But however, the only difference that we basically do in our retreatments or primary root canal treatment irrigation is that we are using tips, flexible tips called as Iriflex that we get from PD, right? And they are basically double vented tips, and they are flexible enough to follow the path of the root canal. And by this, only another thing that we need to take care is while doing irrigation protocol is the force which we are using. So we need to be very gentle by doing that. But the protocol remains the same, and I use 2.5% sodium hypo followed by final rinse of EDTA after the final cleaning and shaping. However, having said that, when we are dealing with cases of retreatment endodontic mishaps with perforations, right, in the beginning, we might use saline, or if the perforation is open, we might use diluted sodium hypochlorite. Do not use fully concentrated or a strong sodium hypochlorite because it has a chance of burning the tissues. So this is basically we need to take care.
Another question from participant named Alex is that, have you used any endodontic retreatment files in the past? If so, what did you like and dislike about them? And compared with the products you used before, what do you think the advantages of Retreatty kit are?
Alex, you have actually asked me to summarize the whole webinar here, right? See, I earlier, yes, we have used files, retreatment files from this Dentsply. We all must have used D1, D2, D3, right? But currently speaking, see, I am not talking about the disadvantages of other systems, or every system has an advantage or disadvantage. But what I am trying to tell you is that Retreaty basically has an advantage of having all the three alloys in one system. That is, you have a gold alloy, you have a silver alloy, and you have a blue alloy. Now, if you know, these alloys have advantages in their own fields. Some give more flexibility. Some help in regaining the shape of the file and maintain the original shape of the root canal. And some are strong enough in removing the gutta percha. Right. Now, this is the alloy part of retreaty. Second part is the design of every file that has been provided, which you must have seen in the webinar, that it is a headstrong design which is given, which easily works, in taking out the gutta percha. All other designs, all other systems, if you see, they are spiral designs. So when they are spiral designs, sometimes it is really difficult. The file doesn't go beyond a certain limit, and gutta percha gets stick to the walls. You must have observed while doing retreatments that while using other systems, many a times the gutta percha gets stick to the walls. Whereas by the virtue of the design of these files in retreaty, since they are H files, almost that shape is given. It scrapes the wall as well as the gutta percha, and the gutta percha automatically you will see debris and gutta percha climbing up. So that is the advantage, because what we used to do earlier was many a times using the other systems for retreatment, we used to use H file. I don't know if you use it or no, but I used to use H file and scrape the wall, root canal wall, to remove the sticking gutta percha. Here you don't need to do that. So this is a basic advantage. And I don't know if you ever, I've never heard of using an H file in a rotary motion, always a scraping motion. So this is the first system that gives you this morphology to be used in rotary motion, because the inside of the system has the core material. Every file has a core, bulk core material, which provides strength to this system. So basically, these are the advantages of retreaty, and rest assured, like we have used it and seen, and that is why we are not recommending a system which we have not used and we don't believe in. We actually believe in this system, we actually have used this system, and once you use it, probably we will be talking on the same page. I hope I'm able to answer your question, Alex.
Yeah, so there's two questions from Divya. One is, what about the use of chlorhexidine? And she asked that, have you done retreatment of a case with good lateral fill? How did you remove uh, the gutta percha from lateral canals? So that was a question. Well,
Divya, thank you for your question. First is, I generally don't use chlorhexidine. I stick to a simple protocol because I want to do a successful root canal treatment, and there is not enough evidence in literature which says that if you are using chlorhexidine, then only you will get a successful root canal treatment, right? We have enough evidence that says that if you are using a combination of sodium hypochlorite and EDTA, you are on the safer side. So I don't want to complex my irrigation protocols. I don't want to already I am doing a complex treatment by treating root canal system, and I don't want to further complex my endo weaponry with a lot of irrigants inside. So I have not used, I don't use chlorhexidine. That is the first question. Second is, I have never treated a case with lateral gutta percha inside. I've never done that. So, but rest assured, if I do so, definitely I'll put it on social media for you.
what happens? Jitendra is asking, what happens if the sealer goes beyond the apex? Is it good in the era of bioceramic sealer, or is it bad when we talk about resin sealers?
Jitender, thank you for this question. Whatever you are using in the root canal, for either for treating or filling the root canal, however biocompatible it is, however good it is a foreign body for the body. Understand, the first concept is this. Sorry. Whether you are using gutta percha to fill, whether you are using MTA for perforation repair or wide open apex closure, whether you are using bioceramic sealers, which are very compatible, whether you are using epoxy resin seal, whatever you are using, it is a foreign body, right? It will definitely have its own reactions. Now, the severity of this reaction is different for every human being. Some might not have any pain, some might have tremendous pain, some might have mild pain, right? So, it is never good to throw something in the periapical area, which is from outside. So, it is never good. So, it is never recommended. Yes, there is an American school of thought which believes in creating a apical puff while doing root canal treatments. But if you are using a resorbable sealer, which will resorb after 6 months or 1 year, then there is no use of making an apical puff, by doing apical gorging or something. There is no use of making an apical puff because eventually this sealer will get resorbed. So if you ask me personally, I don't really like the fact that we throw something in the periapical area. Number one. Second is when you are doing retreatment or when you are doing cases with wide open apices, there are high chances that they will go beyond because it is very difficult to have an apical stop in those cases. So once you do not have apical stop, you just need to try to modify the protocol that you are using so that when you are applying sealer, you come 2 to 3 millimeter behind from the apical part so that when you are pushing the sealer, it doesn't go beyond. When you are putting gutta perca, you put it gently, you do not force, otherwise sealer can be pushed. So all these things you need to just take care. But personally, if you ask me, I am not a very big fan of throwing things in the periapical area because to me it is a foreign body.
Next question is from the anonymous attendee. So he or she is asking how many times is recommended to use this sequence, which is a very common question in India. How many times we can reuse? I would say
Till
you
it
should
will
only use it once. It's a
see,
retreat.
ideally, as I said in my webinar during the presentation also, that all the systems, rotary systems, are single use systems. So the ideal scenario is one time. That's it. And when you are doing retreatment, like Dr. Sanket said very rightly, when you are doing retreatment, you are already into a difficult situation. So you cannot take more chances by reusing certain files, right? So we recommend once, use them once. But if you want to reuse them again, kindly check the system properly for any signs of wear and tear. Kindly check, but that doesn't guarantee that it will not break, right? Understand that doesn't guarantee that it will not break inside your root canal. So, uh, ideally, single time use, but in case you are using it, use it with caution if you are reusing it.
Next question is again from anonymous attendee. In over obturated or in over prepared canals by mistake, what irrigation do you use? I think sir has answered. He uses hypochlorite and EDTA only. In his armamentarium, he does not use chlorhexidine.
I don't use chlorhexidine, but yes, if it's a wide open apex or it's a oval-shaped canals, probably I'll stick to the same protocol. But maybe I dilute my sodium hypochlorite because there are more chances it touches the apical area. So I'll dilute it. But then when I dilute it, I will take care that I prolong the time of irrigation because the game of irrigation does not depend upon the uh, uh, concentration of sodium hypo that you are using, but it depends upon the time for which you are using. If you are using high concentration, you use it for lesser time. If you are using low concentration, you use it for higher time. That's it.
Last question is how do you manage iatrogenic sodium hypochlorite extrusion in periapex in case you encounter while doing it? Because many time in retreatment, the gutta pacha comes out, you unintentionally widen the apex, and when you're irrigating, it may go beyond.
Yes, thank you for this question, and it is a very logical question, as like others. Uh, Sodium hypochlorite accidents, not only in retreatment, but they can also happen in, root canal treatments. Once they happen, the number one thing is kindly immediately flush the root canal system with saline immediately, right? when once you are doing retreatment or root canal treatment, patient is on your chair, the moment patient says with irrigation immense pain is happening, please do not think that it is happening due to root canal instruments, right? Your mind should immediately go to sodium hypochlorite accident. So pick up saline and wash the area nicely. Saline should even go in the periapical area because that is where sodium hypo has gone. So it will have a diluting effect, though it will not give immediate relief to the patient, but it will have a diluting effect which will take care of any continuing effect on the tissues which will happen after this. Number one. Second is patient will have immense pain. So you need to give antibiotic coverage and painkiller to the patient and tell the patient to observe his area where extrusion has happened so that tissue necrosis is not happening. For tissue necrosis, you have already given antibiotic coverage, and for pain, you are giving painkillers. But we need to observe also, visibly observe that tissue necrosis is not happening, and also call the patient every 24 hours, not a phonic call, but call the patient in your clinic to rinse that area again and again with saline and visibly check yourself that tissue necrosis is not happening. So once this sodium hypochlorite accident has happened, depending upon the severity, it will take around 7 days to go down, right? If tissue necrosis has happened, it will take around a week or two to become okay. And in case you really want to see cases with sodium hypochlorite accident, I have published one case. It's on, you will see on the website. If you put sodium hypochlorite Viresh Chopra, one of our students had done it. So we published that case, and you will see tissue necrosis in the vestibular area in the mandibular anteriors, and how we manage the protocol is written there. But the protocol remains the same, which I have told you.
Absolutely, sir. Great. It's really been pleasure to have you on this show, and you have enlightened all of us when it comes to retreatment in endodontics. I think we got a lot of insights into how to go about retreatment. Uh, there's always scope of improvement daily in your practice, as they say, as they use the word practice, because you are never perfect. You always try to, go one step better. So I would like to thank Oscar. I would like to thank Dentist Channel Online and Dr. Viresh Chopra. Thank you very much for your time to enlighten all of us. This video will definitely be, this entire webinar would be available online on the Dentist Channel Online YouTube series. So those who have missed it can definitely have a look at it later in the day. Thank you, Oscar. Would you like to give some concluding remarks?
Uh, Thank you for everyone. Thank you for the great efforts done by Orbit and Dr. Sankey and Dr. Virus. All the questions were welcome to answer again from the online or email to company, Perfect Andrew directly, or to Orbit. To the
Yes.
whole company, you can find the website, and also the retreat kits will have the offline classes very soon in the whole territory of India. So we will see you. We are looking forward to meeting you next time by the real activities.
Thank you. Thank you so much. So you can exit the meeting.
Okay.